So my case is renal artery stenosis and subclavian artery stenosis in a patient of Takayasu arteritis. Are the intervention in these techniques are same like coronary or it's different? Actually, I made probably a lot of mistakes during this intervention. This was done in 2018. So a 14-year-old patient, he presented with fatigue on exertion for last 2 years, and he was hypertensive for last 2 years. BP was controlled despite 4 medications. So he is a case of resistant hypertension, and I have recorded pulse and blood pressure. There is a discrepancy in the pulse and blood pressure in the both upper limb. The blood pressure in the right upper limb is 200 by 100 millimeter of mercury, and in the left upper limb, it is 160 by 80 millimeter of mercury. The lower limb pulse and blood pressure was, there was no discrepancy, but definitely it was high. And I inquired about the family history. There is no family history of hypertension. So these are the investigation report. Hemoglobin was little bit low, 9.7 gram per deciliter. ESR was not very high, 16 millimeter at the end of first hour. Creatinine was normal, 0.9 milligram. Ultrasound QB showed right kidney small and contracted compared to left, and left kidney there is slight corticomedullary alteration. ECG1 done, it was left ventricular hypertrophy, sinus rhythm, echo, there is good LV function. And I did right renal angiography, it was total occlusion, and left renal artery was 80 to 90% stenosis with presence of accessory renal artery, which was also stenosed. And left subclavian artery showed 80 to 90% stenosis, and coronary angiography was normal. So we plan to do a stenting to left renal artery and balloon angioplasty of the accessory renal artery, and also stenting to subclavian artery in the same sitting. So initially, I plan to put a coronary stent instead of renal stent, because the renal stent size was a bit, diameter was normally, the available one is 4 like this. And in our area, it's very difficult to get it because these procedures are not routinely done. And my angiography vessel showed a bit little size. And that was my mistake. So I'll come into the slides. So this is the left renal angiogram, which showed your renal artery stenosis and also stenosis in the accessory renal artery, and right renal artery almost total or subtotal occlusion, you can say. Then these are the coronary angiogram. It was normal. Then subclavian artery stenosis significant in the left side. So I used right femoral approach with JR6F catheter initially, then wet both renal artery and the accessory renal artery, then sequentially dilated with 2 and 3 millimeter balloon. Then this is the finding after dilatation, balloon dilatation. Then I put a stent of 3.5 to 23 millimeter mercury in the main renal artery, left side. And I got optimized result. But if you see the last slide, there is, even after this stent dilatation, there is stenosis in the under dilatation in the mid part. So that again I tried to dilate, post dilate with 4 millimeter balloon, then 4.5 millimeter balloon. I have also taken small balloon so that I can give the radial strength in the mid part, but still I did not get the favorable result. Although it is acceptable, but the result was not very good. So this is the main thing, which is the difference in comparison to coronary. These lesions are very much fibrotic because in Takayasu arteritis we got the intimal fibrosis, and this the situation in coronary is not similar in the Takayasu arteritis or especially in renal artery. Then again, I took this left subclavian artery. So this also I used JR catheter. So initially I dilated with normal PTCA balloon. Then I dilated with peripheral balloon. Then I implanted a 18 to 80 millimeter peripheral stent, and the result comparatively good. So the take-home message is that renal artery stenosis is an important cause of hypertension in young individuals. In Takayasu arteritis, multiple peripheral vessel involvement is found. The lesions are more fibrotic than atherosclerotic lesion. Initial angiogram before balloon dilatation may underestimate the proper size. Coronary stents have less radial strength compared to renal stents. Stents may not expand properly and may need re-intervention, and long-term immunosuppressive therapy is needed to prevent the recurrence. Thank you very much.